Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Tiffany Hensley McBain. Today's episode features content from an educational program titled Cases and Controversies in HIV, A Global Perspective. This podcast features a patient case discussion with Dr. José Arribas from Hospital La Paz IdiPAZ in Madrid, Spain, Dr. Andrew Carr from the University of New South Wales and St. Vincent's Hospital in Sydney, Australia, and Dr. Lynora Saxinger from the University of Alberta in Edmonton, Alberta, Canada. For more information on Dr. Arribas, Dr. Carr, and Dr. Saxinger, and for a link to the full online educational program, including downloadable slides specific to today's discussion, please visit the show notes for this episode. Now, let's get started and hear our expert faculty discuss simplification strategies for a virologically suppressed patient with a complex ART treatment history.
Okay, let's move on to the last case. This is about simplification strategies. And this is a 32-year-old Black woman with perinatally acquired HIV infection. So these are, in general, always very difficult cases. They've been literally all their life taking medications. So recently relocated, and it's the first visit to your office. And she's requesting an ART regimen with as few pills as possible. Her CD4 cell count is 326. Her viral load is 45 copies per ml. Had a history of cervical dysplasia years ago with serial cervical PAPs with normal cytology, negative for high-risk HPV. And you can see on the right the long history of antiretroviral treatment. Started with, you don't have access to all the records, but you know that he started on ACT, then switched to abacavir 3TC cytobudin, then switched in 2003 to a boosted regimen of ACT 3TC lopinavir ritonavir. Then going from a high genetic barrier combination to a low genetic barrier combination, favirenz FTC TDF. Then an hiatus of not taking any antiretroviral. And then at the same time, with a pregnancy, was started on TDF, FTC, atazanavir, ritonavir. That was 2014. And since 2018 to the present, is taking 2 pills. A co-formulation of darunavir with covicistat, along with FTC and TDF. So he's taking 2 pills. He wants to take just 1 pill. So in these patients that you don't have access to all the records, that's something that happens commonly, and who have been through many antiretroviral regimens, and you want to have really a sense of what mutations might be archived. What is your opinion about proviral DNA genotype? Can you do it? Will you order a proviral DNA genotype in these patients? And when do you incorporate proviral DNA genotyping into your practice? So who of you does proviral DNA genotyping?
So the likelihood is that a lot of the regimens were changed for intolerance, but it would be really important to go through each of the pills with her. Now, she probably doesn't remember the names, but if you show them the chart with the pictures of the tablets, they can usually say, I took that one and that one. That one made me sick. That one, gave me headaches. And yeah, I didn't always take that one, right? So that's a very useful discussion. And from the types of combinations she was on, it was boosted lopinavir with zidovudine. Quite likely she didn't take it all, but fairly likely she probably didn't get any resistance from it. So hopefully there might be some thymidine resistance there, but not much more.
I looked at her history and I was thinking that she went through a teen phase. And my experience with the teens are that they commonly actually they have an uncontrolled viral load. It's usually because they haven't taken any of it. And then you have that obvious break in the treatment. So I mean, ordinarily, even if we don't have genotypes along the way, we'll usually be able to piece together a drug history and a series of viral loads that will give us an idea of the risk of whether she actually had, non-suppressive therapy for, durations of time that were of concern. Usually when they're followed by a pediatrician, they get seen every 5 minutes and there's no problems, and then everything goes bad after that. So in this case, it would be one where I think that would be a useful thing to do in the absence of having those records. Similarly, I'm pretty sure I'd have to grovel to someone to get it done, and it's not been part of my practice to date. Usually we go through the old, kind of detective work of drug history, refill history, viral load history, find some old viral loads and send them off for a GART. And that usually actually serves pretty well. So I think there's attraction to this, but it's not been part of my practice to date.
Okay, there is a lot of geographical variation. I think the States, Monogram does the test. And for example, in Europe, in France, they do it a lot. But guidelines always recommend to take the results with a lot of precautions because they can, they lack sensitivity many times because the sampling issue is not the same that doing RNA in plasma. The RNA is distributed to the plasma. You actually have to sample the cells that are infected. And also some of the mutations that you detect might not be relevant because we know that a lot of the reservoir is just virus that is not fully replication competent. So if the mutation is there, might help, but this is not. These results are not easy to interpret. So it's not a difficult test to do, but they do it in-house. It's hospital. You have a virologist that is interested in proviral DNA. You can do it. It's not that difficult. But the results are, we have to say, are difficult to interpret. So you go through this detective work that Lynora was saying. So the patient reports consistent ART adherence since the birth of her son 5 years ago. And you track down a historical genotype 15 years ago. So you do archaeology of mutations that have the M184B. But you perform a proviral DNA genotype, which they know no predicted resistance. That happens sometimes, the proviral DNA genotype. If you don't do, I forgot to mention, you can do just population sequencing with Saxinger, or you can do ultra-deep sequencing. And sometimes if you do Saxinger, you don't pick that mutation that was in a record in the past. As he works as a teacher said, lives with her sister and her son, good family and social support, all aware of her HIV status, never smoke, occasional alcohol use, no previous or current illicit drug use. So you see there are her labs that, has a hemoglobin of 12, platelets 287. So those are, normal labs. He's immune, importantly, to hepatitis A, B, has an antibody negative for hepatitis C virus. His HLA-B5701 is negative. So which regimen would you recommend for this patient who wants to simplify? So here is going, if he wants to simplify, can go from 2 pills or to 1 pill. If we are talking about now, we're talking about oral regimens. We will talk about other type of regimens later on. And remember, she's taking high genetic viral regimen with darunavir covistat plus FTC-TDF. And there you have 3, 5, 6 regimens to pick from, or something else. Who wants to go first? Yeah.
Before I switched, if she's taking tenofovir, 3TC, FTC, I can't remember, and boosted darunavir, she's got a viral load of 45 copies, right? So right. Even if with a 184V, she should be suppressed. So either she's got additional mutations or she's not taking the medicine correctly.
Good
and
point.
In my experience, there are 2 reasons for that, because she's just serially non-adherent. She doesn't take all the pills, or she doesn't take darunavir with food. And over and over again, I've had that experience with patients, even to the point where a patient said, yes, I always take it with food. What time do you have lunch? 1 o'clock. What time do you take the pills? 3 o'clock. Okay. Yeah. So, and then it took about a year to get to that point. So if she really is taking it with food and she really is taking it every day, then I would be inclined to either change the darunavir or add to her current regimen. I see no reason, if she's going to stay where she is, where she might not take option 3, which is, same medicines, 1 pill, boosted darunavir with FTAF in a single pill, right? So that's the most similar to what she's taking. But I suppose I'd like to see a couple of viral loads with her really taking her pills correctly before I did the switch.
Okay, that's a great point. It's just 45. We used to call that undetectable when we have the 50 cutoff, but now it's 45. And it's true that with boosted PIs in general, you see a little bit more, at least in my experience, but I think your points were very well taken, Andrew. Taking it with food is very important, and also review his prescriptions and see if he's taking all the medications by pharmacy records. What will be your option, Lynora?
It's interesting. I was listening to that and I was, interested by the blip. I mean, the low-level detectable viral load. What does that mean in this one in value for this patient? And it makes me nervous. It makes me less happy than if it was fully suppressed. But I mean, seriously, in the bad old days when we had a 400 cutoff, we wouldn't have known about it, and everyone did fine, as far as I recall. Of course, I was just a baby then, and but I'm not sure if that would sway me that much. I would like to know if this has been a frequent issue for her. Because if she is basically almost uniformly undetectable, I don't know if I would change my plan right now based on a 45 times 1. And, she has an M184V, which is not unexpected given her history. The multiple regimens make me a little bit nervous. But she's never had, as I recall, an integrase inhibitor, which I think should be able to do a lot of heavy lifting for her. And so I think I actually would be comfortable giving her an integrase-based regimen, but I would probably be kind of keen to do, some real serious heart-to-heart adherence discussions and a fairly timely viral load follow-up after making a switch. And in practical fact, I probably would go with a bictegravir-based regimen. But again, I think that, because this is a case and we don't have all the information, if there was any suspicion of frequent detectable viral loads or adherence problems, I think that would be a red flag. That might delay my enthusiasm for that particular tactic.
Yeah, my only other comment, I agree with everything you've said. My other comment is I tend to, switch away from boosters, especially in young people, or young people and elderly people. If I cannot give a booster, there is always other doctors that see these patients that do not know about interactions. And for me, it's in general, if I cannot use a booster, for me is something important. Here are several NNRTI-based regimens, such as the doravirine and the lutegravir-rilpivirine. Let's not forget that this lady had been on efavirenz for a long time and might have some NNRTI resistance mutations that have not been detected by the proviral DNA. But there was last options that was something else. I think, Lynora, you're in Canada, you have approved long-acting regimens. I don't know in Australia, Andrew, do you have long-acting already approved?
Not yet. So,
what will be your ideas, your opinions about long-acting injectable ART as a simplified strategy once approved? What barriers do you foresee to implementing in your clinics long-acting injectable ART?
So we're not at the approved in use phase yet, and we're kind of keen on this. I think that this is kind of a niche product for the patients that we see. And to some extent, there are patients, I think, who think, at least in theory, this will be fantastic. I'm not sure if they're going to find it fantastic for the long haul, because the frequency of appointments sounds not bad until you start making them. So to us, when we look at this, we look at our patients who might be maybe needing more support, maybe in a slightly more chaotic environment where the structure actually provides some benefit. And if they're closely affiliated with a clinic where they're often going for other supports, like seeing the social worker or other things, I think that's an excellent setting for this. There are patients who really struggle with taking pills every day and might be amenable to giving this a try. It's kind of idiosyncratic. When I have looked at the literature of long-acting injectable other things, it's very much, I think, patient need and patient desire specific, and I suspect this will be the same. So I'm sure that we'll be offering it to some patients for whom we think it would be a good choice, and then they're going to have to decide if it's a good choice for them. And we probably would be planning to administer it at our clinic presently, and then maybe seeing if we can devolve that to other clinics closer to the patient if that becomes a barrier. So I'm fascinated to see how this is going to roll out. And the other thing I would comment, though, is in a patient like this, like that is a simplification step. But if people are considering trying to conceive, I think that's a big question mark. Really want to make sure that patients who are contemplating this probably have an IUD as contraception until we know more about what this would look like for pregnancy.
Now, I get a lot of questions. Patients tend to get a little disheartened when I explain to them what you've said, that actually you're going to need to come to clinic more often, not less often. You can't inject yourself and you can't do it at home. And so for people who are working, it's a disincentive at the way it's currently structured. Hopefully we can develop sort of more community-focused models of dispensing so it becomes a lot easier for patients, and then I think the uptake will be a lot better.
Good. So my only other comment is that in general, the main driver for patients to want this is, my conversations with them have been a stigma and issues of disclosure. And this lady apparently doesn't have that problem and lives in a very supportive environment, and everybody is aware of her HIV status. But also I like your comment, Lynora, that if women that might become pregnant, they should know that this stays there for a while, even if they stop it. Cabotegravir can stay there for 1 year. So it's very important to have that in the conversation.
Great. Thank you very much, Dr. Arribas, Dr. Carr, and Dr. Saxinger. And thanks to listeners for joining in. As a reminder, to view the full educational program, Cases and Controversies in HIV, A Global Perspective, on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.